Good afternoon. And once again, thanks to Prashant and the team for this kind invitation. I enjoyed my participation yesterday talking about brintuximab in Hodgkin lymphoma. And we have had a wonderful time in this city for last 2 days. Today, I'm going to speak to you on how we treat cutaneous uh, lymphomas, predominantly mycosis fungoides and Sézary syndrome. So cutaneous T cell lymphoma can be a subject by itself to be discussed probably for a few hours. But on the top, you see mycosis fungoides and Sézary syndrome, which together account for almost 60% of the cutaneous T cell lymphomas. And if you look at the conditions underneath and you look at your program, probably most of those conditions are being discussed separately, though not text of skin alone. So that will be a bit of duplication. And given the time of 30 minutes, I thought I'll stick to the commonest of the cutaneous T cell lymphoma, that is mycosis fungoides and the Sézary syndrome. These two conditions worldwide are the top as far as the numbers of cutaneous T cell lymphomas are concerned. But if you look at the data this is the data from Mumbai by our dermatohematopathologist, this falls at number 3 and number 5. And that tells you that there is a lot of ignorance in diagnosing this condition. These patients remain with dermatologists for probably years before somebody thinks of that this could be mycosis fungoides, does a biopsy, and that biopsy is interpreted properly. So we are talking about non-Hodgkin lymphomas, which present with skin lesions, and they may involve blood, they may involve lymph node. Two main types, mycosis and Sézary. They are symptomatic diseases, they cause disfiguring, and there is uncontrollable pruritus affecting almost 60 to 80% of patients. And they significantly affect the quality of life. Given that this is cutaneous and extracutaneous manifestation of these two common lymphomas, it cannot be managed by one individual. And the three important disciplinary which have to be involved is, of course, a hemato-oncologist, a dermato-oncologist, and a radiation oncologist. Physical examination is to assess the type and the extent of the skin disease, and large number of oncologists do not strip the patient totally to see where the disease is. And this disease essentially occurs in areas which are not exposed to sun, and therefore it has to be really searched by stripping the patient totally. And the lymph nodes also have to be examined. From the angle of diagnosis, skin biopsy, of course, is mandatory for histology, immunohistochemistry, and as and when required, to look at the T cell receptor gene rearrangement, which again, what was said and done, is in the preliminary state in this country with a lot of wrong reporting. The lab workup required is to do the Sézary cell count, circulating T cell subsets, and once again the clonality. Imaging is not a must like in various low-grade lymphomas, but sometimes you require PET CT scan, but that should not be wasted in good number of patients. And this exactly tells you the whole story of Anita. She saw 2 dermatologists, 1 allergy specialist, underwent 3 biopsies to make a diagnosis of mycosis fungoides. And this is probably a very modest way. You can multiply it by that you see 20 dermatologists, probably 10 allergies, and undergo 30 biopsies before you diagnose mycosis fungoides. Area of the skin that is involved is important in staging this lymphoma, and that should be done very carefully. The biopsies also have to be done very carefully. This shows you exactly what a punch biopsy it is done, and this tells you how an excision biopsy is done. And unless you provide this kind of tissue to a dermatohistopathologist, you will not get the proper diagnosis. As was mentioned, staging system exists. It is extremely important to exactly give the nature of treatment that the patient deserves. And it is based on the skin involvement, that is T, lymph node involvement, the N, the visceral involvement, including marrow, that is M, and the blood involvement B. So T and M, B classification. Sometimes the lesions may be extremely small, and a magnifying glass has to be used by the dermatologist, which they do, I suppose. I'll show you some examples of various kind of manifestations. The left side upper, you have a solitary pink annular patch On the right side, you have multiple pink ovoid patches. Here you have plaques covering more than 10% of the surface. And here you have ulcerated tumors together with red annular patches and plaques. And here you have the Sézary syndrome, which is an erythroderma. Rest of the time I'll spend on the treatment. The treatment can be divided into three parts rather. One is the skin-directed therapies. And skin-directed therapies could be various kind of topical applications and the phototherapy. The second is the radiation therapy, and the third is the systemic therapies. The goal of the treatment is not cure because that's not possible. So you control the disease. That will improve the quality of life. And also because many of these patients finally succumb to infection, prevent the infection. We will see two cases, a case of early stage mycosis fungoides and a case of advanced stage mycosis fungoides. And we'll discuss the approach to the treatment of both one by one. So let's first take up the first case of limited stage disease. Old woman presented for the evaluation of a pruritic patch on her trunk, which was there for a year. Eczema was the diagnosis and topical steroids were used, but they were ineffective. She was referred after an outside biopsy showed that this is mycosis fungoides. She had hyperpigmented scaly patch on both the involving less than 10% body surface area. She had no constitutional symptoms whatsoever. Physical examination for lymphadenopathy was negative. A second skin biopsy was done to confirm the diagnosis, which included histology, immunohistology, and the receptor T cell receptor gene rearrangement, and that confirms fungoides. The flow cytometry of the blood was negative, so there were no circulating cells, and therefore stage 1A MF was diagnosed. As steroid ointment had already failed, she was put on NB-UVB, that is narrowband ultraviolet B phototherapy, given 3 times in a week with slowly increasing the titration of the dose. Initially, the response was pretty good, but after about 6 months, she developed thick plaques and the treatment was failing. At this stage, she took the oral bexaroten. She is a worker in the French embassy and she could have an easy access, which was given in the dose of 300 milligram daily. She had a good response. The NB-UVB phototherapy was decreased to twice in a week. So far, so good. She's doing fine. So that's our first case of limited stage mycosis fungoides. And this gives us an opportunity to discuss the treatment of early stage mycosis fungoides. So these are patients who have patches or plaques, and the treatment is usually skin directed. So it's either topical agents or phototherapy or both. The choice of the skin-directed therapy will be based on the type of the skin lesion, the extent of the body involved, the therapy side effect profile, the provider's experience, and the patient's tolerance and adherence to the committed regimen. What are the topical agents that you have? You have corticosteroids, you have chemotherapeutic agents like nitrogen mustard, and you have bexaroten. The preferred start with topical steroids is because the response is good, they are easily available, they are cheap, and the side effect profile is reasonable. So topical steroids is usually the first line of treatment for these patients. How does steroid work? They are sort of anti-inflammatory. They decrease the lymphocyte adhesion to the endothelium. They induce apoptosis. They downregulate the pro-inflammatory transcription factors, and they decrease the production of the cytokine growth factors. In a prospective study of 79 patients, 51 of those were T1, 28 were T2 of primarily patches treated with topical corticosteroids twice daily and followed up for 9 months. It was shown that there was a clinical clearing, which was total in 32 patients with T1 disease, 63%, and partial remission in 16, that is 31%, overall response being over 90%. Patients with T2 disease, that is patches and plaques involving more than 10% body surface area, the overall response was about 80% with CR of 25%. However, these responses are not very prolonged. On topical steroid discontinuation, only 37% of T1 and 18% of T2 patients remained in CR. What the type of steroid that you should choose? Then clobesterol propionate 0.5% is the preferred agent because of its rapidity with which it controls the disease. The other factors which are important is to choose ointment versus cream, and also the anatomical site that is involved and the disease state, because there can be thick skin of the palm and sole, there can be thin skin like the eyelid, and there could be an area which is inflamed where the absorption of steroid ointment may be better. There can be some side effects of corticosteroids. The skin undergo atrophy, which is usually reversible. There can be loss of pigmentation. There can be striae formation. Adrenal suppression secondary to local cream usually does not take place. The second topical treatment is nitrogen mustard. Nitrogen mustard, as you know, is a byproduct. This can be applied topically, also known as miclorathamine. It's a cytotoxic alkylating agent, as we all know. When administered systemically, we know how it works. It causes the direct DNA damage, but one doesn't know exact mechanism of action when it is applied topically. Maybe it has immunogenic effects, and some research exists there. The complete response rate is more than that of steroid, that is 50 to 85% if it is T1 disease, and it is 30 to 60% if it is T2 disease. It's available at 0.016% gel. Most popular brand available is Velclor. Again, it's an imported brand that is available. And phase 2 trial led to the FDA approval. This trial was a reasonably large trial of 260 patients. And the efficacy was, overall response rate was 58.5%, CR of 13.8%, and average time for which the response lasted about 6.5 months. Side effect profile included skin irritation, erythema, pruritus. True allergic contact dermatitis is less common with gel formulation than with the ointment. Side effects can be minimized by gradually increasing the frequency of application, using it together with topical corticosteroids, and decreasing the frequency. There is some kind of possibility of secondary cutaneous malignancies, which was shown in initial studies. However, subsequently, this was ruled out. Now we have 30-year population-based cohort study that was published in 2014, and there was no increase in or non-melanomatous skin cancers. Carmustine is another drug, cancer chemotherapy drug that can be applied locally, that is BICNU. It's not very popular, not like nitrogen mustard, but it has been shown to be as effective as nitrogen mustard. And the third one, and probably the very important one, is the bexaroten gel, available by this name, Targretine. It's expensive. It again has to be imported. Not everybody can have an easy access to it. It's a synthetic retinoid which binds to the retinoid X receptor. Topical 1% gel is approved by the US FDA for early stage mycosis fungoides. The oral form we will come to very soon. It also down-regulates the cell adhesion molecules and thereby decreasing the malignant T cell trafficking to the skin. Exact mechanism of oral bexaroten activity is clear. Phase 1, phase 2 trial of 1% gel after a median of 20 weeks of treatment. Overall response was 63%, the CR rate was 21%. The main side effect was irritation at the site, especially when it is applied multiple times in a day. This can be minimized by applying it gradually once a day and gradually increasing its frequency of application. There are some other topical agents available like retinoids, imiquimod, 5-fluorouracil, and tacrolimus. They are much less popular than the first three that we talked about. The second skin-oriented treatment is phototherapy. And the phototherapy is the one which you use for vitiligo, UVB, as we discussed in our patient already. So the use of topical agent is primary approach in patients with solitary patch and few patches. The initial treatment approach of patients with T2 disease, primarily patches, is to use phototherapy, especially the narrow band B light, which a wavelength of 311. It suppresses the neoplastic T cells by inhibiting the antigen presenting cells. It is thought to increase the keratinocyte cytokine production. The complete remission rates by using this kind of phototherapy in early stages is around 50 to 90%, average being 75% when it is used 3 times in a week. The studies have shown better response for patch than plaque. Hypopigmented variants of mycosis fungoides respond better than the dark skin persons. After cessation of phototherapy, relapses can occur in 80 to 100% of patients. The mean interval after which the relapses occur is 6 to 15 months. And therefore, prolonged maintenance therapy could be of some use. One should use frequently, that is thrice in a week during the period of active disease, and then make it less often. Maintenance therapy may have to be used because, as you saw again, that the disease does come back. The second kind of skin-directed phototherapy is what is very popular is PUA phototherapy, P for the psoralen and UVA is the light that you use. So this one modality involves the administration of oral psoralen compound, which sensitizes the skin to a UVA radiation. It has the advantage of deeper penetration than UVB, and it is more effective in patients who have got plaques. The adverse effect profile of PUA is something with which you are uncomfortable. It can cause good amount of causes photosensitivity. In long term, there is photo aging, there is increased risk of cataracts and increased risk of non-melanoma skin cancer. Because of this side effect profile, this kind of skin-directed phototherapy is not very popular because you've got oral agents to treat the stage plaque. There is one less commonly used type of, again, phototherapy, which is called monochromic excimer light, which is again not very popular. Then electron beam therapy. So total skin electron beam therapy is a commonly used type of modality. So total skin electron, which involves the administration of superficially penetrant ionizing radiation. The advantage of electron beam is it does not go beyond the epidermis. So it can be given to the whole body without any side effects. The conventional doses which were used in past were 30 to 36 gray. They are no more used. They were quite effective. And today one uses just about 10 to 12 gray, which is sufficient. Side effect profile is erythema, desquamation, xerosis, anhidrosis, nail atrophy, and alopecia. So much about the case 1, which was limited stage. We move on to case 2, which may be probably more relevant and exciting to the medical oncologist. So this is a 65-year-old woman presented with continued management of her mycosis fungoides. She had initially received NB-UVB phototherapy at diagnosis, but she developed new plaques. She developed tumorous stage on the left elbow, right forearm, and left ankle. She was given local radiotherapy, to which she responded. She was also put on then oral methotrexate, 15 milligram per week. But finally, both these treatment modalities started failing. Romidepsin was started, once again, a molecule which is not easily available here. And this led to partial regression. She remained on this treatment for 9 months together with the local application of steroids. After 9 using romidepsin, she had another skin plaque which developed. Biopsy showed that there is a large cell transformation, and this large cell transformation was CD30 positive. This is known to occur in 25 to 30% of patients. So diagnosis of large cell transformation was peripheral blood flow cytometry remained negative. Because this was CD30 positive large cell transformation, patient was put on brentuximab vedotin at the dose of 1.8 milligram per kg once every 3 weeks. After first 3 cycles, patient had partial regression of the both patches and plaques without development of. She developed grade 1 neuropathy after 6 cycles, and therefore the dose of BV, as we discussed yesterday, was reduced to from 1.8 to 1.2 milligram per meter square every 3 weeks. The neuropathy resolved. She continued on this schedule for 12 cycles. At this time, she developed neuropathy grade 1. And this time, as she was already on the lowest dose, the frequency was reduced from 3 weeks to 4 weeks. And that once again took care of her neuropathy. And she continues this treatment till today. So that's our case number 2. And this allows us to discuss the treatment of advanced stage disease. Once again, you should do complete skin examination. Here, it is even more important to do the proper flow of the blood to rule out Sézary cells presence over there. You look at least CD4, CD7, and CD26. And here is a situation where probably you should do a CT PET scan also. Clinically, progression includes onset of new skin lesions. Typically, these are plaque and tumors, or development of extracutaneous tissue in the form of lymph nodes, which are involved by the disease. At the time of skin progression, additional skin biopsies are recommended to see that there is no large cell transformation, and complete immunophenotyping is also required. We come to the treatment of systemic therapy. So systemic therapy, the mycosis fungoides is best treated by systemic therapy in combination with the skin-directed therapy, either applications or radiation. The overall response to the systemic therapy is between 30 to 45%, except for brentuximab vedotin, which is extremely powerful agent. Additional systemic agents lead to partial response rather than complete response. And therefore, the goal is actually to just improve the quality of life and control the disease to the maximum possible extent. The drugs which are commonly used are methotrexate, and in the Western world, bexarotene by mouth. Treatment is continued in the maintenance fashion until the response is lost, the patient starts progressing again. And you should combine it with the skin-directed therapy to minimize local problems. So the one which is most common in India is methotrexate plus minus interferon. And yes, bexarotene probably comes on the top in the Western world, but because of its cost and poor availability, is not the most popular agent here. So we'll discuss methotrexate first. You can go right up to the dose of anywhere up to 50 milligram per week, depending upon the tolerance of the person. 33% overall response rate in T2 stage, starts failing by about a little over 1 year. The overall response was in 58% of patients in another study. Interferons, alpha interferon and gamma interferon, both have been shown to be effective. There has been no proper systematic study on this particular compound, but in clinical practice it is effective, and one often uses methotrexate and interferon in combination. Bexarotene is a little dream for most of us. This is a synthetic selective retinoid agonist, which has got anti-proliferative activity against the tumor cell, and US FDA has approved it for the refractory CTL. The phase 2-3 trial showed it in the dose of 300 milligram per meter square to be extremely effective, and the median duration of response being about 9 months. Side effect profile is hyperlipidemia and central hypothyroidism with low TSH. And these are all manageable side effects. The one is available in India in some centers, especially in Chennai, is extracorporeal photopheresis, and we have been sending patients for this. This is a very effective modality of treatment, especially for Sézary syndrome, where you can do two sitting on one by in a consecutive fashion every month for about 6 months. This is extremely effective modality and is the first line of choice for Sézary syndrome. What exactly is done over here may be best seen in this particular cartoon. So you start from here. The whole blood is fractionated via centrifugation. Leukocyte-rich buffy coat is isolated. Red blood cell plasma returned to the patient. The sorrelin-like compound is added to the buffy coat, and this is treated with UVA light, and then this treated buffy coat is returned to the patient. So those are the steps of the extracorporeal photopheresis, not available in all parts of this country, but available in this country. And that's the equipment for photopheresis. We come to the last part of my talk, and that is targeted therapies. Targeted therapies are plenty: romidepsin, vorinostat, brentuximab vedotin, and this mogamulizumab. Romidepsin has been time tested. It is class 1 HDAC inhibitor, US FDA approved after failure of one line of treatment. Response rates about 34%, complete remission rate of only 6%, median duration of response 15 months. Major side effects: GI symptoms, low blood counts, and prolongation of QT interval. Vorinostat is an oral pan inhibitor, again approved after failure of 2 lines of treatment, and again has an overall response of 30%. Antibody-based therapy, probably the most exciting, is the brentuximab vedotin. It's an antibody drug conjugate about which we discussed yesterday. It targets CD30, which is expressed in almost all mycosis patient. And this is a large phase 3 Alcanza study. Patients with previously treated CD30 positive MF were randomized to receive brentuximab versus physician's choice, which was either methotrexate or bexarotene. Overall response rate was 67%, which is highest than any other in BV arm versus 20% in the methotrexate or the bexarotene arm. Median progression-free survival with BV was superior, and it was 16 months versus 3.5 months in the control arm. Peripheral sensory neuropathy does occur, as we discussed yesterday, and the same details apply here, so I need not spend more time. Mogamulizumab is another injectable targeted therapy. It's a humanized monoclonal antibody against CC cytokine receptor 4, so CCR4, which is expressed on the surface of the malignant T lymphocytes. And there's this phase 3 MOVARIC study where previously treated fungoides or Sézary cases were randomized to receive this versus vorinostat. And the primary endpoint was progression-free survival, which was 7.7 months versus 3 months in the control. The overall response was superior in patients who received it. Common side effects include infusion-related reactions, skin eruption, and diarrhea. There's a place for checkpoint inhibitors, not exactly very great, but they have been used. Phase 1 study of nivolumab, overall response of 15%. Phase 2 study of Pembro, overall response rate of 38%. Toxicities are like any other, but one notable toxicity is a flare-up or worsening of the pruritus in Sézary cases. A word on large cell transformation. Large cell transformation can occur in 25% of patients, and invariably CD30 expression is associated. Therefore, there is a tremendous role of brentuximab vedotin in these patients. Other drugs that have been used are romidepsin, etc. But these patients are often treated like you treat a large cell transformation. In clinical practice, you also use CHOP or CHOIP, etc. And there have been single drug chemotherapy drugs also used, like gemcitabine, liposomal doxorubicin, or pegylated liposomal doxorubicin. So this is probably my last slide, which summarizes all the agents that you have at your disposal. The first left is the skin-directed therapy. The middle is the systemic therapies. And the last one is a combination of skin and systemic therapy. What is important is to realize that these are non-curable indolent diseases. The treatment should be proportionate to the problem of the patient. The idea is to improve the quality of life and control the disease with minimum side effects and the cost to the patient for the maximum possible time. Probably a patient will require A to Z all these drugs in his lifetime. And if you use them very judiciously, don't jump the gun too much, then probably you save these agents for the treatment at an appropriate time. So that's sort of my conclusion. Thank you so much.
Sir, any option for a financially challenged patient or who has progressed on methotrexate?
Who has progressed on
methotrexate, yes.
So what do we do really? If it's an advanced phase disease, we are using interferon, or we're sending them to Chennai for photopheresis. So I don't think we have used anything beyond methotrexate, interferon, and photopheresis. Most of the patients are not able to afford any drug which is imported. They're expensive. The cost involved is tremendous.
The photopheresis,
it's available in Adyar. If somebody is here from Adyar. You have in Ames also. Okay, okay. Sorry for that lack of information.
Yeah, please, Meek. So if just to answer your question, if the patient is lucky, he may get compassionate access to brentuximab. Some of these have excessive. Some for some time it may be open. Yeah.
Sir, CTCL, not SS. Initially failed CHEOP. After 6 cycle progressed. On compassionate procured brentuximab, but after 1 cycle has a progressive disease. So compassionate means doesn't have much of funds, but yeah, if we need to support beyond that, what alternative do we have now?
You're talking about mycosis fungoides? Who has
CTCL, yes sir, MF without SS. No blood spill.
Yeah, who has progressed on brentuximab 1 cycle.
Correct, sir.
So I don't think I have any different answer than what we've discussed. First of all, you won't use brentuximab too much in front. By the time you reached brentuximab, I suppose you have used everything.
So beyond CHEOP, tried for BV. After CHEOP, 6 cycles, received brentuximab.
And it has failed.
And it has failed.
You're talking about what other chemotherapy can be used?
So as in, sir, what will be your choice now? That's what.
Okay, so it's a frustrating disease. Combination chemotherapy is the last step. Brentuximab itself is the last step. When you've used this, there aren't many very effective options which can last for very long. You can use any one of the chemotherapeutic agents that I talked about. That way we have used cladribine, we have used some other drugs also, gemcitabine based protocols. Effects has been 1 month, 2 months, 3 months. That's about all. So I don't think you have some great option or great choice, or there are some great trials to tell you which one to use first, which one to use next. Very often I prefer to use one agent and go to the second agent, go to the third agent. Don't jump to combination chemotherapy. Brentuximab, of course, is for the small number of patients who can afford it. None of these drugs will be effective in 100% of patients. None of these drugs will work for very long, and that length is in few weeks to few months. So you can just play between those chemotherapeutic agents. And I don't think one is superior to the other, or there's any order in which you'll use them. Nothing of that.
So I have one question. So what do you feel is the role for pembrolizumab? Some of the refractory cases. There is some data for IO, but
Pembrolizumab,
yeah.
I showed you the data.
Yeah,
Phase
there is
2 trials are there, 30%, 40%.
that's the only response.
And the response
Just extrapolating from that and extrapolating the low dose Nevo study from Hodgkin lymphoma, if you have a poor patient using a lower dose of IO with some combination chemotherapy similar to what you did for Hodgkin lymphoma, could be a possible answer. Just a theoretical answer. Thank you so much, sir.
Thank you.